Have you ever wondered what's in our blood? What it can tell about our well-being? What about the innovative technology used to unravel the mystery of what's in our blood? Hello, I'm Dean Whiting, and this is It's in Our Blood, the podcast series that explores the critical role technology plays in the pathology laboratory, in hospitals, and in the community setting. So in today's podcast, I'm extremely fortunate to be sitting right next to Professor Mark Shepherd, OAM, Director of Flinders University International Centre for Point of Care Testing. Mark and I go back an awfully long way. We were trying to think of how far back we go, but it's got to be, I guess, 20 years, Mark, hasn't it? Yeah. So welcome and thank you for joining us.
Thanks, Dean.
And since I haven't seen Mark since, what did we say?
2011.
2011. And since then, his service, point of care testing service, has really expanded out of where, when I knew Mark, it was into diabetes testing, hemoglobin A1C in the QALMS project and in the rural and remote setting. But now it's also expanded into point of care pathology and into sexually transmitted infections. So Mark is a perfect person to help us understand some of the important aspects of our technology and how it contributes to the better patient outcomes and better health economic outcomes in the point of care and in the rural and remote setting. So Mark, I guess the first question is really, from your perspective, what's the importance of point of care testing at that point of care in the rural and remote environment? Why is it important to do that?
Well, I think there's a lot of advantages for using point of care testing in rural and remote settings. It really relates to geographic isolation, I guess, of the remote services, meaning that sending pathology samples to the nearest laboratory, which may be hundreds or even 1,000 kilometres away from the service, just the actual transport time taken to get the sample to the laboratory, get it analysed and then get the results back to the health service mean that the patient generally has gone away by the time the result comes back, and therefore the patient has to come back again for a second visit. So for point of care testing to be able to be done on the spot while the patient's there in front of the doctor, the results can be available generally within a 10 or a 15 minute time frame for most point of care tests, and the patient can get their treatment there and then on the spot, so they go away feeling comfortable, enjoying the experience of having the point of care testing done, and happy to come back for the next time they're recalled. So it's really about patient satisfaction and convenience, and really the quick turnaround time expedites the pathology process, I guess.
Yeah. And I guess the technology itself is the technology itself needs to be amenable for using at the point of care. And as I mentioned at the outset, you've got diabetes covered, sexually transmitted diseases covered, a couple of other areas covered as well. What other sorts of testing?
Acute point of care testing, particularly in the Northern Territory, we have an iStat network involving more than 100 devices now, and every remote health facility in the Northern Territory has an iStat device, and they're particularly used for acute medical emergencies, with the electrolytes and blood gas test profile being very commonly used. But in the Northern Territory, because of the high rates of rheumatic heart disease, the INR test that the iStat has on its test suite is used widely as well. So it's a very versatile device for a range of important medical conditions. And in the infectious disease area, we have a network of 32 remote health services, all testing for chlamydia, gonorrhea and trichomonas using a molecular-based testing device, the GeneXpert. I guess the GeneXpert has really revolutionised the way STI testing is conducted within Australia and around the world, because The problem with lateral flow technology for many of the infectious disease tests is the lack of sensitivity, but the GeneXpert, working on the method principle of DNA amplification, is highly sensitive and highly specific, so it provides laboratory equivalent results at the point of care. But with the Tango program, it's a global first, I guess. It's the device had not previously been used in a primary care setting, so we've been able to take the device outside of the laboratory and put it into a primary care setting where it's proven to be very reliable and very well accepted by the health professional staff using it. I guess that's another advantage of point of care testing, is that the technology itself, most point of care devices are made to be relatively simple to operate with minimal manual steps, I guess, and so we've been able to train a range of other health professionals, such as Aboriginal health workers or Aboriginal health practitioners, as well as remote area nurses, to use the technology in their remote settings. And we've done many satisfaction surveys which show that these other health professional groups can perform point of care testing to a very high analytical standard, but they also enjoy the challenge of using that technology in a remote setting.
Yeah, I think that's captured a huge part of what I was expecting, and certainly what I know of the past when we've discussed it. But maybe distill this down a little bit for the implication for patients of the near patient testing. I mean, our point of care testing, why is it important for the patient groups?
Well, I think it empowers the patient to take responsibility for their own health. So we work particularly with Indigenous people, and I guess there is quite a stigma around having a laboratory sample taken from an Aboriginal person and then sent off to a laboratory that the patient doesn't know where that laboratory is. They don't know what's happening to their sample. Whereas with point of care testing, they can see their own blood sample, for example, being taken from their finger, put onto a device next to them, and that technology can give them a result within 5 minutes to 10 minutes. So when that number or test result comes up on the screen, the patient actually takes ownership of that number, and the number, they know it's their blood sample, they know that result belongs to them, and therefore they're more empowered to take control of their own health and want to change and improve their health because of the whole point of care testing process. And
I recall, when I was still involved with this, I recall that there was some quite startling reductions in hemoglobin A1C, for example, in the communities where they were doing this testing. Can you just relate one of those to us? What was one of your findings there? We did a study in the Northern Territory which showed that in one particular cohort of patients there was a 2.8% reduction in hemoglobin A1C over a 15-month period since point of care testing had been introduced. Prior to that time, we were able to track the hemoglobin A1Cs on those patients for the 15 months preceding point of care testing. There was virtually no change in the HbA1c level, but following the introduction of point of care, as I say, we saw up to a 2.8% reduction, which is a significant improvement in diabetes control and significant reduction in risk of complications. But also we found that the average time taken for the turnaround time for the laboratory result prior to point of care was about 2.25 days, whereas with point of care testing the results available in front of the patient within that 6-minute window that the test takes to complete. So the patients, I think, really enjoy point of care testing. We've had lots of examples where the patients feel comfortable enough to actually come back. They want to come back to the clinic for their next test because they've been satisfied with the process of point of care testing. And as I say, it's all about ownership and control of their own health information and wanting to improve their own health. Exactly.
Through access to point of care
Exactly.
testing.
And I mean, a 2.8% reduction in hemoglobin A1C is going to significantly reduce those really very significant complications, for heart disease, for
Yep.
blood, for circulatory disorders, for blindness, for all these sorts of things. So
I mean, the test result prompts the patient to be more medication compliant, I guess, if you like, because they've enjoyed the process. They know their hemoglobin A1C, for example, is high, but they can reduce it by adherence to medication. So I think medication adherence has resulted in those improved HbA1cs that we've seen to be sustainable over the long term.
this podcast is brought to you by Pathology Technology Australia, the peak body representing the companies who invent, manufacture, supply and support the vital technology needed for testing those precious patient samples. Did you know that pathology tests provide vital information for about 70% of medical diagnosis and 100% of cancer diagnosis? Pathology Technology Australia, representing the companies who provide the innovative technology so critical to a high quality, affordable and accessible healthcare system. And you mentioned the Tango study previously with infectious disease testing. You've also noticed a significant health economic benefit for testing, for example, the infectious diseases closer to the patient as well. Can you tell me a little bit about that?
Well, we found that the use of a device like the GeneXpert, again, it's related to the accessibility and convenience of the device within the health service, but from a health economic point of view, we're just conducting the final analysis of that health economics data, but it's certainly showing that the point of care testing process is equivalent to, if not slightly more cost effective than the laboratory process. Where we've seen the greatest health economic benefit is in the Northern Territory point of care testing program, which is the acute testing program that uses the iStat device for those important emergency tests. We conducted a study through a grant we received from the Emergency Medicine Foundation in Queensland to look at the health benefit of point of care testing, particularly in relation to, say, medical retrievals. And so we looked at 3 clinical conditions across 200 patients at 6 different remote health services, small, medium and large health services, and we were able to show through a detailed economic evaluation that point of care testing was saving the Northern Territory health system overall around $21 million per annum in saved medical retrievals, just for those 3 clinical conditions that we looked at.
Oh, and I mean, in my personal opinion is that the more we look into the benefits, the health economic benefits of point of care testing, the more we will find that the technology saves money, doesn't cost money. And I think that's the big realisation here is that, technology shouldn't be seen as a cost side, it should be seen as a benefit side.
Cost saving, yeah. So I think there's no doubt about that. With the Northern Territory point of care testing program, we've seen the clinical benefits that flow as well as the cost effective benefits, but really I think good solid cost analysis studies in the point of care field is the area that's lacking. There's a lot of publications around the operational benefits of point of care, the clinical benefits of point of care, and also in our hands the cultural benefits of point of care, but it's the studies on cost analysis that I think need more attention from people working within the point of care field. I guess we're in a fortunate situation being a research centre here at Flinders. We can look at things like cost benefit through our connections with health economists. So I see that really collaboration with health economists moving forward is a really important component of point of care testing, studies and research moving forward, because they are the people that can help design and also analyse the results far better than, say, a medical scientist, for example.
Yeah.
But we need their expertise as part of our collaborative research to get those cost-benefit analyses. Because I really feel that most of the modern point-of-care technology, it's accurate and precise, or sensitive and specific if it's an infectious disease test, and provided you've got a good quality framework around the introduction of point-of-care testing, the economic benefits should flow as well as the clinical benefits.
Well, you've led perfectly to my last, the last part of this, and that is, I recall when we were working together, you were so proud of the fact that the hemoglobin A1Cs that you were performing in rural and remote areas, when compared in an external quality assurance program, when compared to laboratory-based testing, there was no real difference in the quality of the service from rural and remote to the large laboratory. And I assume in the years, that hasn't changed. That's stayed about the same.
We certainly, in the early part of the QAMS program, the government was particularly keen for us to monitor the quality of the system. And we produced a lot of early data to show that the point-of-care testing for hemoglobin A1C and ACR was equivalent to laboratory standards, but we've extrapolated that over the years, and recently we published a study looking at 15 years of quality assurance data, which showed that there was no statistically significant difference between the imprecision for point-of-care testing for HbA1c compared to the median performance of Australian laboratories. So for that sort of test, we've got very long-term data, and similarly for the Tango study and the Northern Territory study, we're constantly comparing the quality of testing based on quality control and quality assurance testing against laboratory benchmarks, and it's possible to get analytical equivalence across tests for chronic, acute and infectious diseases. There's no doubt about that. And we've also got evidence in the Northern Territory, for example, in 2015, we actually doubled the size of the program, and we were concerned then that in that immediate post-doubling phase of the project that we wouldn't be able to maintain the quality, but in fact we were. So we found no diminution in the quality of testing, even in the face of a doubling of the actual devices within that particular point-of-care network. So I think that that attention to detail about the training, so making the health professionals performing point-of-care testing, aware of exactly how the program works and what we're trying to achieve through a really good training program and competency register, and then following that up with constant analytical surveillance means that a network can be sustainable in the long term in terms of that quality, despite, as I say, for example, a doubling in the size of health workers, of health services in a program, or the constant change of health professionals within the rural and remote framework. One of the biggest challenges in rural and remote health is the turnover of staff. So to be able to maintain quality in the face of the turnover of staff within services and across services it's important to demonstrate to governments, for example, that point of care can stand up and is robust within that sort of system.
No, yeah, and I recall I participated, I think, in a few of the, for a number of years, in a few of the training sessions, and we would hold them in various places around, either in a metro area or in a rural and remote setting. But from my perspective, and distilling down what you say, there's three key aspects to the quality framework. One is good training and certification. Two is good support. So when something does go wrong, they've got a number to call. And three is to have, say, a quality assessment process, which works for that setting. And it has to be specific for that setting, because we're not a mainframe huge city laboratory. We're distributed about the community in all sorts of places. So that quality assessment process has to be contextualised to that.
And on top of that, I think one of the advantages our centre has as an independent research centre, I guess, within a university framework is that we are able to provide an intensive level of support services, whereas perhaps laboratories may not have the resources or the time to do that. And that's definitely an undervalued component of point of care testing that really needs to be in place for a network to be sustainable, to be able to provide that intensive level of support, and also to build the relationship with your consumer base. So, we have our scientific team is on the phone constantly, all day, every day, talking to services about how they're going, any issues or problems that they have, how we can help resolve them, maintenance of participation in quality testing programs, providing feedback to the services on how their service is going and how their technology within their hands is operating. So we can tell any operator within any service at any point in time what the imprecision of their HbA1c device is, for example, and they're interested to know that. So I think that's part of the education process. But that two-way sort of communication, relationship building and support service framework is also a critical but underestimated element of a good point of care network.
Yeah. Oh, it's a look. To my way of thinking, point of care provides us with an extremely important path forward, not only in a rural and remote setting, but maybe also in a urban setting as well, where we can catch people before they need to be hospitalised. Get people to take more responsibility for their treatment. So I think what you've done serves as a great model for how we could be taking healthcare, developing healthcare far more in the future. So, Mark, it was great to catch up with you. I really appreciate the time, I think this serves as a great example of astute use of good quality technology in the right way in a rural and remote setting to not only help our patients but also to improve the health economy as well. So, thank you, Mark. I really appreciate it.
Thanks, Dean. Thanks for your support over all the years.
You're welcome. Absolutely. Good, and that ends this podcast. Certainly look out for more podcasts on these topics and more coming along soon. Thank you for listening to this edition of It's in Our Blood. Look out for further topics in this series or go to pathologytechnology.org.au. This podcast is produced by London Agency, Melbourne, Australia.